I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the June 2016 PRS Journal Club podcast. I'm Amanda Silva, and I'm joined by my fellow PRS resident ambassadors Sammy, Sinno, and Raj Sawh-Martinez. Today, we welcome our guest discussant, Dr. Rohrich, who really needs no introduction, but amongst his many accolades is the editor-in-chief of Plastic and Reconstructive Surgery Journal, and the reason why we even are able to bring you this podcast. Today, we'll be discussing an article on Drolet by Drolet et al. Out of Brown, entitled Unnecessary Emergency Transfers for Evaluation by a Plastic Surgeon, a Burden to Patients and to the Healthcare System. So the authors sought to identify the frequency and impact of unnecessary transfers for emergency evaluation by a plastic surgeon at their Level 1 trauma center. They reviewed more than 30,000 consecutive ED encounters at their institution, and they looked at patients specifically who had a chief complaint of a hand or a face trauma and excluded any polytrauma patients. They found 1,181 patients that were transferred for evaluation at their facility. They then performed a retrospective chart review and determined the necessity of transfer based on the intervention that was performed at their hospital and the availability of the resources at the transferring site. They found that about a third of patients that were transferred received no intervention, about a third received intervention in the ER, and about 60% of those were performed by the plastic surgery service and the rest by the ER. Only 2.5% required emergent surgery. About 10 were admitted to plastics. About 10% were admitted to another service, and about 12% were discharged without any follow-up necessary. Of all of the consults that came in, they deemed that 74% were unnecessary. The hand-related issues were significantly more likely to be considered unnecessary compared to the facial and infection consults. If you look at Figure 1, that's a nice figure that looks at the outcomes and whether they deemed them necessary or not. So it's a good one to look at. They secondarily looked at whether the patients had favorable or unfavorable insurance to tease out whether certain patients were sent during different times of day. Patients that had less favorable insurance were significantly more likely to be unnecessarily transferred than those with favorable insurance. And then they specifically looked at during off hours if there was a trend. And they have a nice figure, Figure 3, when you look at that shows that they had a statistically higher proportion of patients with unfavorable insurance that were transferred during these off hours. However, that proportion of unnecessary transfers is not significantly different. They also looked at, of the 15 ERs that transferred patients, whether they had resources available at their hospital. And they noted that 12 of those 15 had a full-time hand surgeon on coverage, and that 7 of the 15 had face coverage as well. The average time from referral to discharge from their ED once the patient was transferred was 412 minutes, and they calculated that the average expense per unnecessary transfer was $5,400, which, when you add that all up, exceeded $4.6 million. So it's a really interesting study. And they started to kind of touch on solutions, but I think kind of the next conversation is how, we know this is a problem. What do we do now? What are the possible solutions so that we can move on from this point? So, Dr. Rohrich, I'd be curious if you have any thoughts.
Well, Amanda, a great summary. I applaud these authors for the bravery of actually telling us exactly what we all know is a huge national issue in the emergency field, and especially for plastic surgery and hand surgery, the unnecessary transfer of patients from non-level 1 hospitals to level 1 hospitals in this country that is just not necessary and unregulated, and there are no set guidelines. I think this study begs the need for national guidelines for transferring patients or not transferring patients. And because almost 3/4 were unnecessarily transferred because either they had a negative wallet biopsy or it was off hours and it was just not needed. I mean, It's so heartfelt because all of us are in level 1 trauma centers and we're the recipient of these. And it just pains me because, first of all, it's not good care. It impedes patient safety, and it's very, very costly. I mean, I think this $4.6 million is an incredibly small number for what I think the actual number is for not only, the cost to the hospitals, the physicians, the unnecessary, transportation costs, all of those things. I mean, I think this is a very important study, but it does beg, where do you go from here? And I would say we need national guidelines on when not to transfer. We have them on, when they can and cannot transfer for other things, but these, and of course this happens in other specialties as well, but it's really highlighted in hand and facial trauma in this article.
Yeah, one of the supplemental articles that we have talks about this a little bit, about, where can we go from here? And one of the things that they suggested was looking at maybe just trying to start small, so looking at patients who have fingertip amputations and criteria for transfer, whether to try to hone in on something small, or do you think we need to do a more global picture?
No, I think it should be more global, so that we that are at these recipient centers can say, okay, did you follow these specific guidelines for transfer? And if they have an on-call, even if it's a level 2 hand surgeon, if they have a level 2 trauma center, if they have an on-call hand surgeon or plastic surgeon, they need to be called directly and then have them transferred from those folks, because many times it's the ER doctor calling you and they haven't even called their plastic surgeon on call. So I think there should be at least some broad sweeping criteria on calling to come from the primary specialty of the other hospital, if there is certainly a specialty on call, because I think that would diminish it significantly. And they should also, by federal guidelines, hospitals have to treat patients that if they're underinsured or not insured, if they're going to receive federal funding. So, but you know what? We don't monitor that well for the subspecialty transfers. We monitor it for the major transfers, trauma especially. I mean, major trauma.
Yeah, I agree. And I think, obviously we recently reviewed another article in the journal about the need for increased subspecialization in hand surgery in certain areas of the country. I think that would help. And you're right, Dr. Rohrich and Amanda, a lot of times when you're on the phone with the hospital that's trying to transfer, it's a lot of times a language barrier. They obviously can't understand some of the terms that we're trying to use to describe the injury. And I think by setting up broad guidelines and educating those other facilities, I think we can start to improve our care of the patients, which is most important.
Yeah, and I really think that in the future, the use of telemedicine is going to be critical. This could cut down these unnecessary transfers by probably 80-90% if you could say,
great point.
Okay, show me the patient, and this is what you ask the patient to do. Because many times they say, oh, it's a replant, and obviously you're looking at it and thinking pink, and yet it just needs a flexor tendon repair. And so I think we should mandate telemedicine video looked at the patient and a face-to-face, and that would resolve it. That is going to be the new area where we can be cost-effective, I feel.
Yeah, these are all great points, and this is a really awesome study, and I think it's going to hit home to absolutely every resident who takes these calls, and certainly every attending who then, owns these patients, so to speak. I think for me, there are sort of 2 or 3 things that really struck me. One is their figure 3 and sort of the timing of transfers, which I thought was really hilarious in the sense that this is something that we all empirically sort of always think, but this is putting data to it where it's at 5, 7 o'clock evening transfers where now there's no local person in-house, doesn't want to take care of it. They don't want, this patient's now there late, just send them to the big referral center, number 1. Number 2, it's the stats of the insurance status of patients. And that, I think we all see it, tertiary referral centers, we don't say no to anyone. And sort of this sort of feeding happens, which is really going to be an interesting phenomenon. What's going to happen now as reimbursements keep getting cut to these big hospital systems, not being able to take care of patients now who are uninsured or underinsured. We're as a specialty where we, are there to help everyone. We always say yes to everyone. I think it is one of those things that will become potentially untenable for our big hospital systems. And I think Dr. Rohrich, you nailed it hit the nail on the head where, telemedicine and use of adjuncts will be critical, but it's all to me about education. And if people are not educated enough on what is okay and not okay to transfer, this is going to be a perpetual problem.
Yeah, I agree. And this is one of the few times where I think it needs to, believe me, I'm not into legislating, but I think is one of the few times where in emergency medicine, we need to legislate guidelines, because otherwise there's so much abuse, because it then puts the hospitals on notice saying, I need to have the resources to have somebody evaluate this hand, this facial fracture, rather than having the complete 100% dumping syndrome that we all see nationally. So I applaud this group from Brown for really taking a stand that actually, permeates throughout every part of the United States.
Mm-hmm.
Great.
Yeah, great discussion. Thanks.